Good afternoon. Thank you for joining us for the New England Sleep Medicine Seminar Series today. Information on how to log your CME will be available in the chat in a few minutes and updated periodically. Today we're joined by Dr. Chitra Lal, who's going to be speaking on OSA and dementia. She's a professor of pulmonary critical care and sleep medicine and the medical director of the sleep program at the University
Hello
of
there,
Yale.
Chitra. How are you?
Good, how are you?
Good.
And prior to this, she served as the professor of medicine at the Medical University of South Carolina at Charleston, South Carolina. She's also served as the immediate past chair of the Sleep Network of the American College of Chest Physicians and is currently a member of the ATS Sleep and Respiratory Neurobiology Program Committee. She serves as the chair of an ASM guideline on treatment of excessive daytime sleepiness among patients with OSA. She's co-authored several publications in Chest, JCSM, and regularly invited to speak on sleep disorders at international conferences. Her research focus has been on obstructive sleep apnea with a special interest in cognitive impairment in OSA and has mentored several residents and fellows, encouraging them to pursue careers in sleep medicine over the years. So without further ado, Dr. Well, we're very excited to have you here today.
Thank you so much for that kind introduction. So, Gul, and great to see a lot of familiar faces online. Hi, Claire. So, always good to see you. Um, this slide is about my disclosures and CME information for you. Okay, so basically, I'm going to talk about some of the evidence linking cognitive impairment to OSA. We'll talk about some biomarkers and scales that can be used to measure cognition in OSA patients, and also evaluate the impact of OSA treatment on dementia and mild cognitive impairment. So I'll basically go over some of my earlier research in the field, and then a workshop that we worked on for the American Thoracic Society, and then subsequent salient studies that have come out in this area. So, sleep apnea, obstructive sleep apnea specifically is a really common problem, as is Alzheimer's disease. And Alzheimer's disease accounts for about 60 to 70% of all dementias. Now, a prodrome to Alzheimer's is mild cognitive impairment, which is basically involvement of usually one cognitive domain, most commonly memory, so which is known as amnestic MCI. And the reason we care about MCI is because it progresses to Alzheimer's disease at the rate of about 10 to 15% per year. So the thought is that if we intervene at the stage of MCI, if there are modifiable risk factors that can be targeted potentially, then we might prevent the development of dementia as a downstream effect. OSA is highly prevalent in Alzheimer's disease, and there's a lot of emerging evidence that it's a risk factor for preclinical Alzheimer's disease. It's also been associated with MCI. And there are several early studies which have shown that the prevalence of MCI in OSA is about 25%. And it's possible that this relationship is bidirectional, but we don't have, enough evidence to support the bidirectional nature right now, although it is certainly biologically plausible that OSA worsens Alzheimer's disease and vice versa. Alzheimer's disease can worsen OSA because of its impact on the respiratory neurons. So I've been interested in this field for a number of years, and one of my earlier papers was a review article in Chest in 2012. So the first step was to review the currently available evidence. And when we looked at potential risk factors through which OSA might mediate cognitive decline, there are several. I mean, there are independent risk factors associated with OSA, which independently impact cognition, like obesity, stroke, congestive heart failure, use of psychoactive drugs like statins or statins, for example. Actually, surprisingly, statins also have a black box warning for OSA, for cognitive impairment, especially the lipid-soluble statins. Then alcohol, smoking, there are static risk factors like age and gender, Down syndrome, apolipoprotein E4, which is one of the strongest genetic markers for Alzheimer's disease. And then OSA causes excessive daytime sleepiness, and we all know EDS has an impact on cognition. It can also cause some dysregulation of inflammatory biomarkers. It can upregulate inflammatory biomarkers and cause endothelial dysfunction, ultimately resulting in cognitive deficits through all these various mechanisms. I was funded early on in my career through SCORE, which is the Specialized Center of Research, and this was in South Carolina when I was faculty there. And I was interested in looking at the impact of OSA on cognition in postmenopausal women. So we know that menopause is a risk factor for sleep apnea. The prevalence of sleep apnea increases dramatically when women transition into menopause. In addition to that, perimenopausal women complain of cognitive issues. So that's not uncommon. And we know that sleep apnea is associated with mild cognitive impairment. So menopausal symptoms can be treated with HRT, but HRT obviously has adverse effects like, higher risk of thromboembolic events. So if OSA is an independent risk factor for cognitive issues in the menopausal state, then perhaps treating OSA might improve some of the cognitive deficits that are seen in early menopause. So the question we asked was, does OSA impact cognition in early postmenopausal women? Our hypothesis was that early postmenopausal women with sleep apnea would have higher mean MCFSI scores. So MCFSI stands for the Mail-in Cognitive Function Screening Instrument. This was like a 14-item questionnaire which was validated in elderly men in like a dementia screening cohort to see what scores might indicate early onset of dementia or MCI. And it's easy to use in clinic. So basically, this is what we use for this study as well. And higher scores are worse than MCFSI. So basically, the hypothesis was that early postmenopausal women with sleep apnea would have higher scores on MCFSI compared to those without sleep apnea, even after adjusting for traditional risk factors for cognitive impairment. Our aim one was to compare cognitive function in postmenopausal women with and without sleep apnea. And aim two was to perform a pilot and feasibility study of functional MRI in early postmenopausal women with sleep apnea. These were women between 45 to 60 years of age within 5 years of natural menopause, so no menstrual bleeding for a year or more, which is how menopause was defined. They were not on hormone replacement therapy. Sleep apnea risk was defined by a Berlin questionnaire. Cognition was measured with MCFSI. We collected data through REDCap surveys, and we collected blood to do some biomarker assays in the future. And looking at a 25% prevalence of cognitive impairment and sleep apnea, we thought that we needed an N of 200 to detect a difference of 1.5 points on an MCFSI, which correlates to the standard deviation, which you see around a score of like 2.5, which is what is the normal score you would see. In the original study which validated this, although the study where this was validated was a non-sleep apnea population, but we extrapolated it to a sleep apnea population, there was essentially no score that has been specifically validated in sleep apnea, actually. So this is what the Mail-in Cognitive Function Screening Instrument looks like. It's a battery of 14 questions, and they basically ask about things like, have you been misplacing things? Has your memory declined? Do you have more problems managing money? Do you get disoriented easily? And yes would get a score of 1, no was 0, maybe was 0.5. So this we have used both as a binary variable where a score of 5 or greater would be considered abnormal, which is like 2 standard deviations over that score of 2.5, which would be considered like the mean. And then, we've also used it as a continuous variable where higher scores would be considered worse. So there were 381 survey respondents, of whom 127 got excluded for various reasons. Either they were not in the right age range, or they were not within 5 years of menopause, or it was surgical menopause, or they were on HRT, or they had missing data. So at the end, we basically included 254 subjects, 154 of whom were at high risk for sleep apnea, and 100 were at low risk for sleep apnea. So basically, we did not do sleep studies in these patients since we didn't have enough funding to do that. This was sleep apnea at risk as measured with the Berlin questionnaire. So those at risk versus those at low risk. And we found that the mean MCFSI scores in women at high sleep apnea risk were higher as compared to women at low sleep apnea risk. So the average score in the high sleep apnea risk group was 5.59 compared to 4.29 in the low sleep apnea group. So not a difference of 1.5 points, but close. But the difference was statistically significant. So essentially, we concluded that women at high sleep apnea risk reported more cognitive issues than women at low sleep apnea risk. We had also collected some blood to do a proteomic analysis, later, and this was actually done like a few years later after the original study. And the hypothesis was that the proteomic signatures would be different in sleep apnea patients who had cognitive impairment compared to sleep apnea patients who did not report any cognitive issues. So this was just an exploratory large-scale proteomic analysis, and we picked a convenience population, those with high MCFSI scores versus low MCFSI scores, and the N was 6 in each group, so it was just a small pilot study of a convenience sample. And proteomic analysis was done, it was outsourced, it was done by Myriad IBM using ELISA, and we did a pathway analysis using the uniprot identifier and string for Homo sapiens. So these were the demographic variables of the two groups. The main difference was obviously in the MCFSI scores. The cognitively impaired group had significantly higher scores than those who did not have cognitive issues. And hypertension was reported only in the group with cognitive impairment. Diabetes, heart disease, and stroke, which are independent risk factors for cognitive impairment, were not reported. There was no difference in the prevalence of depression in the group. And again, depression has an impact on cognition as well. So there was no difference in that prevalence. And the results of the protein analysis were adjusted for hypertension. So these were the results. There were some proteins which were underexpressed and some which were overexpressed in the cognitively impaired group. And I mean, I don't want to go with each of these individual ones, but there were proteins which are protective against neurodegeneration, like adiponectin, pentrexin, which were underexpressed in the cognitively impaired group. And then there were proteins which are markers of axonal injury and neurodegeneration, like the serpin proteins. So there are some serpin proteins which are considered anti-aging, but then there are others which are actually markers of neurodegeneration. And those specific serpin proteins, E1 and F1, were actually overexpressed in this group, as was insulin and angiopoietin 1. So we conducted a heat map to see if the proteomic signatures were different, and that's on the right-hand side. So each column is one subject, and the first 6 were the subjects with cognitive issues. The next 6 were those without cognitive issues. The color red basically indicated underexpressed proteins, and blue was for overexpressed proteins. And as you can see, I mean, they seem to have like swapped out on each side. So what was underexpressed in the cognitively impaired group was overexpressed in the other group and vice versa. So the signatures looked really different on proteomic analysis. We did a pathway analysis using string, and basically it seemed that there was a central regulatory role for insulin. There were roles for small vessel ischemia and obesity-driven inflammation. And we compared this to historical controls from Alzheimer's disease. And we found the same directionality of several of these biomarkers, like insulin is increased in Alzheimer's disease. It was increased in our cognitively impaired sleep apnea group. Same with angiopoietin 1, interleukin 1 beta, and adiponectin was decreased in both. The main difference is that Alzheimer's patients tend to be older. They're usually over 65, and our sleep apnea group was somewhat younger. These were postmenopausal women, but they were between 45 to 60. So this was a younger cohort. But they seem to have the same biomarker derangements that you would see in Alzheimer's, which might imply that the neuropathology, related to MCI and dementia in sleep apnea patients might be developing at a much earlier age group. So sleep apnea potentially could be a modifiable risk factor for cognitive impairment. Obviously, you would need larger studies to confirm these results, but I'll share some other studies that have come out from other authors in recent years, which have found similar results in terms of biomarker derangements in sleep apnea patients who report cognitive issues. So following this, we applied for funding for an ATS workshop because there had never been a workshop from the American Thoracic Society on this topic. And this was funded through the American Thoracic Society with the primary project assembly was the SRN assembly. This was an 8-hour virtual workshop, so it was held during the pandemic. And it was logistically challenging and interesting because we had participants from, the southern hemisphere. So the times were totally different in Australia and New Zealand compared to here. But we had a really engaged panel that was very multidisciplinary. And I'll go over some salient findings of the workshop. So one of the things, like everybody on the workshop was not a neurologist. So we had our neurology colleague on the group provide a brief overview of what Alzheimer's disease looks like. And I'm a pulmonologist, so I'm not a neurologist by training. So this was quite helpful to actually hear this review as it was for the other participants. So essentially, the pathophysiology of Alzheimer's begins several decades before the clinical manifestations occur. And actually, the biomarker derangements like deposition of decreased CSF in plasma, amyloid beta, increased phosphorylated tau, all these things begin like 4 to 5 decades before the clinical manifestations happen. These changes can be picked up with PET imaging and structural brain MRIs eventually. And Alzheimer's has a heterogeneous course, eventually resulting in memory decline, impaired language, visuospatial, and executive functioning. And patients eventually die because of intercurrent illness, usually pneumonia, which happens 4 to 10 years after the diagnosis. One common theme in Alzheimer's is hippocampal atrophy, which is also seen in sleep apnea patients. And the hippocampus is involved in memory. So, and it's involved, it's basically hippocampal atrophy seen in Alzheimer's and also seen in sleep apnea, which is kind of interesting. And memory loss is one of the common cognitive impacts of obstructive sleep apnea. Um, so, OSA has been shown to impact memory across various forms of memory, actually, and it also negatively impacts a sleep-dependent form of spatial navigational memory. That uses medial temporal lobe structures, including regions that are affected the earliest by Alzheimer's disease pathology. It also results in poorer overnight memory consolidation for those who are otherwise cognitively intact. And, this is something that we have all experienced. If you have fragmented sleep or you're sleep deprived, whatever, you learned the prior night, you won't recall is not as great the next day. So OSA causes sleep fragmentation, and it's not entirely clear if the impact on memory is because of the hypoxia or the sleep fragmentation or a combination of both. A small RCT of diet and exercise with or without PAP basically showed that 3 months of PAP could improve memory to levels seen in individuals without sleep apnea. So even 3 months of PAP was enough to produce improvement. And these changes correlated with increased slow wave sleep after starting PAP therapy. In the Alzheimer's Neuroimaging Initiative, the average age of onset of MCI was about 10 years earlier in subjects with self-reported untreated OSA, so around the age of 72.6 years, as compared to subjects without self-reported OSA, where the onset of MCI was delayed up to 83.6 years. And in those who used PAP, the average age of conversion to MCI was again delayed by 10 years, so similar to subjects without self-reported OSA, which would seem to imply that CPAP can delay the onset of cognitive issues, and it's somewhat neuroprotective. We reviewed some of the epidemiology of cognitive impairments in OSA, and one of the studies we looked at was the study of osteoporotic fractures in older women. And in those with moderate sleep apnea, they were found to be at a higher risk of developing MCI or dementia over 5 years than those without sleep apnea. There are meta-analyses which have shown similar findings. But the results are somewhat heterogeneous and inconsistent if you look at the literature in this field. And part of the reason is that OSA is defined variably. Whether you use microarousals or a 3 or a 4% desaturation can impact what you see. The study designs are variable, population characteristics are variable. There's also the impact of cognitive reserve, which is how much one is able to withstand certain cognitive insults. which can be impacted by education level, for example, and intellect, and that can vary over a lifetime. It doesn't remain the same. And also which cognitive outcomes were studied, whether it was memory versus vigilance versus executive function, because executive function we know is somewhat more resistant to the impact of treatment because it might imply a more chronic underlying neuropathology. And also the duration of follow-up in studies. So the data in this field is somewhat heterogeneous, but the bulk of studies do indicate that there is an association between cognitive issues and OSA. And it's hypoxemia, which seems to be more strongly associated with cognitive issues than the AHI. Um, so, how do you screen for cognitive impairment in sleep apnea patients? There is no screening test that is validated specifically in OSA patients. The tests which have been used have been validated in non-OSA patients and have been extrapolated to the OSA patient population. So one of the concerns is that the cutoffs that you use to define MCI and dementia may not apply to an OSA population. For example, for many mental states, a score of less than 23 is dementia and 23 to 26 would be MCI. But if you apply that to OSA patients, it only correctly identified about 60% of those who had OSA with MCI. So it has been hypothesized that the optimal threshold to detect MCI and dementia in OSA might be higher, which is actually, these are close to normal values of 30 and 29. And they say that 30 should be used for mild OSA and 29 for moderate to severe OSA. But even there, you only pick up 2/3 of the patients who actually had MCI in the sleep apnea population. Similarly, in Montreal Cognitive Assessment or MoCA, which is used really commonly, the validated score to detect MCI is 26. But in the sleep apnea patients, that can only pick up about 69 to 75% of the patients. So again, it has been hypothesized that we should use higher scores, like 27 or 28, to pick up MCI in an OSA population. But even then, it doesn't perform that well. It might still only pick up about 80% of those patients who have OSA with MCI. So I think that has to be considered when we do clinical trials or use these scores in an OSA patient population, that these are not validated in those populations. There are brain changes that go along with cognitive issues in OSA, and these include gray matter and white matter loss. But the commonest finding is that there is hippocampal atrophy, and that seems to be consistently impacted in obstructive sleep apnea. And some of these brain changes can actually be reversed with CPAP. So this was an earlier study from Canessa's group in 2011. So the panel on top shows, on the right-hand side, shows gray matter reduction prior to treatment for sleep apnea. And then after 3 months of CPAP, there was some gray matter increase, which correlated with improved performance and executive function as measured by the Stroop test, as shown below that. So even 3 months of CPAP treatment can improve the brain changes and improve cognitive task performance. But obviously, neuroimaging is expensive. It has limitations. It's not that widely available in clinical practice. This is not something that would be used routinely. It can be combined with things like high density EEG or other biomarker imaging with PET scanning or even plasma biomarkers, which might be easier to measure when you're actually looking at cognitive changes in OSA and association with Alzheimer's disease neurodegeneration. Microarousals happen frequently in obstructive sleep apnea patients, and they can increase neural activity, which can increase production of amyloid and tau. And sleep apnea also decreases glymphatic flow. So glymph basically washes out the toxins in the brain. So if it decreases glymphatic flow, it results in poorer clearance of amyloid and tau. And sleep apnea can also cause direct neural injury through the intermittent episodic hypoxia that is seen, and ischemic reperfusion injury and vascular parenchymal inflammation. So there are blood-based AD biomarkers which are being used increasingly because they are scalable and easier to measure, and they could potentially be used as treatment outcomes in future OSA clinical trials, like light chain plasma neurofilament light would be one, for example, and these can be measured. So at the end of the day, we care about whether treating sleep apnea is going to improve cognition. I mean, that's what it essentially boils down to. And if you treat people, then how long do you treat them? So there are a couple of studies which have looked at this, and I'm highlighting a few of these here. So there was an earlier meta-analysis which found a small impact on attention in favor of CPAP with improvement in sleepiness. So sustained attention or vigilance is obviously consistently impacted in sleep apnea, and that directly influences driving safety. So that is a cognitive domain we do care about. And excessive daytime sleepiness also impacts vigilance. So some of this effect of CPAP on vigilance comes through the improvement in EDS or excessive daytime sleepiness. Similarly, there are other studies which have shown similar results with improvements in sleepiness and some other cognitive tasks like digit span and digital symbol tests. There was a very large cohort called the PROOF cohort, prognostic indicator of cardiovascular and cerebrovascular events, where cognitive testing was done in all subjects with sleep apnea at baseline and then 10 years later. And CPAP was found to maintain memory, attention, and executive functioning. So CPAP seemed to be protective over time. So 3 months of CPAP treatment has been shown to improve cognitive outcomes. A month of CPAP treatment might produce some improvements in memory, and obviously it will improve EDS and vigilance to a degree. Anything shorter than that has actually not been shown to have any cognitive benefits. But I think the premise here would be that the longer you treat and the more compliant patients are, the more benefit you would see. But you would, in general, need to treat patients for at least 3 to 6 months with CPAP in order to see an improvement in cognitive deficits. But most of the data comes on CPAP. There's really no substantial data on other treatment options for OSA. I mean, there's one study on a mandibular advancing splint, and I know there's some data on hypoglossal nerve stimulation, there's some studies which are currently being done, but there is no substantial published data on other treatment options other than CPAP at this point. There are some cognitive domains which are more sensitive to the effect of OSA treatment than others. Obviously, vigilance or sustained attention would be something that responds relatively quickly because EDS or excessive daytime sleepiness impacts that. So you treat EDS, vigilance tends to get better. Memory usually will show some improvement. Working memory, for example, will show some improvements. Executive functioning generally does not improve that much because it might reflect a more chronic underlying neuropathology. So an example of executive functioning would be like multitasking. And we can use tests like Wisconsin card sorting in clinical trials to measure, that's a measure of executive function, for example, and the Stroop test that I mentioned earlier. And the other thing is what time of day the cognitive tasks are performed, because people perform differently in the morning as compared to the afternoon. During the afternoon, there's a dip in circadian alertness. So cognitive task performance actually goes down in the afternoon compared to the morning. Cognitive reserve is difficult to measure. It can also change over a lifetime. And there are some cognitive domains which haven't been studied that well, which probably should be studied, like overnight motor learning, because that can be impacted by OSA as well. There are racial and ethnic disparities in both Alzheimer's disease and obstructive sleep apnea, and most of these, disparities are seen in African Americans and Hispanic populations. I mean, as a percentage of the U.S. population, these are actually a small percentage of the population. But when you look at Alzheimer's disease and OSA prevalence, they are overrepresented in those groups. So OSA is more common in these particular populations. So that might be the mechanism because of which you also see high rates of Alzheimer's disease in Hispanics and African Americans. But this should be a focus of future clinical trials to basically increase diversity in clinical trial recruitment and try to retain those populations. The workshop went over some future directions for clinical trial design. Basically generalized trials trying to recruit everybody with OSA would be costly and not everybody has cognitive deficits from OSA. So maybe targeting an enriched population, for example, from memory clinics where there's a high prevalence of OSA. or patients with other risk factors like who are apolipoprotein E4 positive, who have more severe hypoxia or OSA, who have preclinical Alzheimer's or cardiac disease, which are independent risk factors for cognitive impairment as well, might yield more enriched populations where where you don't need that big a sample size to actually study them. And blood-based biomarkers could be a viable and scalable and actually cost-effective screening tool for those with preclinical AD in the future. They also talked about propensity score matching as an observational equivalent to conducting randomized control trials because RCTs, are expensive and you have to find baseline deficits in order to show an improvement with treatment. For example, like the Apple study, which was a really, now it's a relatively older study in 2012 or 2013, was a negative study. And it looked at cognitive impairment in OSA. And one reason was that participants did not have a lot of deficits at baseline. So if you don't have a lot of deficits at baseline, it's hard to show improvement. So you basically need an enriched patient population with risk factors for cognitive issues. And then the choice of the cognitive test is really important because, like we said earlier, some of these are not validated. Actually, most of these are not validated in OSA patient population. So maybe using different cutoffs when these tests are used in a sleep apnea population. So I've used the NIH toolbox, which is really comprehensive, and the MCFSI isn't validated for sleep apnea, but we have a few papers where we use that. So, using a cutoff which might actually show, which might be relatively valid for that patient population would be important. Neuroimaging is expensive and not readily available. So outside the context of a clinical trial, that would probably not be something that would be widely applicable. CSF biomarkers are invasive. So I think plasma biomarkers probably is the way to go because these are relatively easily measurable and scalable and more readily available. And they're sensitive and, can show some changes over time. So the workshop concluded that there was a lot of evidence showing an association between OSA and cognitive issues, and the cognitive screening tests that we currently use should be interpreted with caution. Most of the data on OSA treatment on cognition is for CPAP, so we clearly need some data on other treatment options as well. There's a lot of heterogeneity as to which cognitive domains might improve with CPAP, which again could relate to study design, cognitive reserve, and the aspect of each cognitive domain that is studied. And again, there is strong biological plausibility, but not a lot of data to prove that this is a bidirectional association between OSA and Alzheimer's disease. And key considerations for the future would be to select more diverse patient populations to enroll in these trials, look at new approaches for improving PAP adherence, and studying changes in more easily accessible biomarkers like plasma biomarkers. This was published in 2022. And since this workshop, there has been some additional data which has emerged looking at the association between OSA and cognitive impairment. And I wanted to highlight some of the more recent studies which have come out. So one of these was from the Albion cohort. And I think Albion is agenation longitudinal biomarker intervention of neurodegeneration, if I remember that correctly. So that was the Albion cohort. The mean age was around 64.4 years, and they actually had 70% women. So women were really well represented in this group. Their median education was 14 years with a median BMI of 26, and they did one night of watch PAT. And sleep apnea was measured by the 3% AHI definition. In this study, they found that higher AHI might contribute to cognitive impairment, either independently or with Alzheimer's disease pathology. So this is one of those few studies where AHI was actually linked to more strongly to cognitive issues. So most of the data in the past has shown that it's the ODI, the oxygen desaturation index, which correlates more closely with cognitive issues as compared to the AHI. And then there was a meta-analysis of about 23 studies where the pooled prevalence of cognitive impairment in adult OSA patients was about 36.9%. And when a subgroup analysis was done, they found that the prevalence of cognitive impairment went up with the severity of sleep apnea. So it was 32.2% in mild OSA, 36.79% in moderate OSA, and 44.46% in severe OSA. So this was another study where the AHI was found to be associated with the severity of cognitive issues or the prevalence of cognitive impairment. In a controlled study, sleep apnea patients showed a higher risk of developing all-cause dementia, Alzheimer's disease, and vascular dementia, and hazard ratios were relatively high as compared to those without OSA, like 4 to 5 times higher. Interestingly, it was obstructive sleep apnea patients who were less than 52 years of age who had the highest risk of all-cause dementia. And this was consistent for also vascular dementia and Alzheimer's disease. So basically, it seems that a younger age at OSA onset was associated with a higher risk of dementia, possibly because patients have untreated OSA for years. So that insult of that episodic intermittent hypoxia, is happening over several years and causes some microneuronal brain damage, which eventually increases the risk for dementia over time. So this could be a particularly vulnerable patient population for developing dementia that could potentially be targeted for earlier intervention. In other words, aggressive screening and treatment for sleep apnea. And then in a study of MCI patients, so this was a cohort of 104 MCI patients recruited from a memory clinic. The prevalence of OSA was high, about 58.7%, and moderate to severe OSA was 25%. But only 13% of these patients reported daytime sleepiness. So just relying on sleepiness as a screening tool for OSA in a memory clinic is probably not the best. You probably want to use a more robust screening tool, something like stop bang, for example, but not rely just on symptoms like EDS. And these are some biomarker studies which came out relatively recently. In a meta-analysis of 18 studies, they found that CSF amyloid beta, blood total amyloid beta, and blood total tau were higher in OSA patients compared to healthy controls, suggesting that sleep apnea has an elevation of some biomarkers of Alzheimer's disease. And then serum alpha-synuclein was found to be significantly elevated in another study in OSA patients compared to controls. And alpha-synuclein has been independently associated with cognitive impairment in OSA. So there is some emerging data, again, that there are some biomarkers of Alzheimer's disease which are deranged in OSA patients as well, but at a much earlier age. There are some recent treatment studies which have come out. So 12 months of CPAP use in one study was found to be associated with attenuated cognitive decline and domain-specific gains in Alzheimer's disease-related MCI with OSA. And these correlated with longer N3 sleep and REM sleep and greater total sleep time. Also, right side sleeping was associated with better cognitive outcomes. So I think it's basically that if you sleep supine, sleep apnea is worse. So non-supine sleeping was associated with better cognitive outcomes. And extended N2 sleep, wakefulness, and supine sleeping had poorer outcomes. In the Memories 2 study, which is changing the trajectory of MCI with CPAP treatment of OSA, participants who had moderate to severe OSA were CPAP naive, got telehealth CPAP adherence intervention. Their mean age was around 67 years and adequate representation from both men and women. The mean AHI was in the severe range, and 73.6% patients were adherent to CPAP. But Caucasian and white patients had a 9.94 times higher odds of adhering to CPAP compared to Black patients. So basically, patients with amnestic MCI or memory loss can have a high CPAP adherence. So just because they have cognitive issues, it should not be a barrier to treat patients because adherence can be achieved in these patients, but there are some racial differences. So possibly targeting, poorly adherent patients and trying to make sure they use CPAP regularly would be important. But age and cognitive issues are not a barrier to prescribing CPAP. So there is a distinct link between OSA, mild cognitive impairment, and dementia with possible bidirectional causality, although again, there is not enough evidence to prove that bidirectional link. And there is evidence that sleep apnea
How is
is
it?
a
looks okay.
There's evidence that sleep apnea is a modifiable risk factor for dementia and that CPAP treatment might improve cognitive outcomes in OSA patients. And thank you for your attention. I'd be happy to take any questions.
Thank you so much, Dr. Lal. So our first question on the chat is asking about your opinion about which biomarker seems to be most relevant to predict cognitive impairment. And then they put increasing N3 prevalence power and or REM or resolution of hypoxic burden.
So they are asking about plasma biomarkers or stages of sleep or ODI. It's not clear. I'm sorry.
Viviana, would you mind confirming? It sounds like they're asking about stages, sleep stages, or markers of sleep apnea severity. But feel free to clarify if that's not correct.
So I think the bulk of the data from the clinical trials that have been done so far is that it's the hypoxic burden which is more closely associated with cognitive issues than the AHI. So the ODI, or the time spent with oxygen saturation below 88%, and actually, there's one researcher, I think, at Harvard, who works in Dr. Redline's group, who has come up with a measure, a T90 or something like that, which is the amount of time spent below 90%, or the nadir of oxygen saturation. So he has studied that actually with cardiovascular disease, but the same also applies to cognitive issues. And most of the studies have actually shown that ODI is linked more closely to cognitive impairment than AHI. Was that the question, or was there another aspect to it?
She was asking about, I think, sleep stages. She clarified later in the chat about whether any of them, reductions versus hypoxia, have increased risk of Alzheimer's.
So I think the one of the recent studies basically alluded to the fact that if you have more N2 sleep, there's and at the cost of decreasing N3 and REM, there's a greater risk of cognitive issues. There's also other EEG markers that have been studied, like spindle density and K density, which have been looked at. But I think those are still under study, so there's not a lot of data on how these are correlated with cognitive issues.
Oh, so predominantly reduced N3, REM,
and REM sleep,
hypoxic burden. Okay.
And hypoxic burden, yes.
And then another question, they said, Dr. Yagi said, thank you for a great talk. Can you comment on the data on GLP-1s and cognitive impairment and dementia?
Yeah, so that's a wonderful question. Thanks for asking that, Dr. Yagi. So GLP-1s might have some impact on orexin. So they might have some impact on regulation of the sleep-wake cycle. I think that is still an area of study. So if they truly do have an impact on orexin, which is the wakefulness hormone, then I think the downstream effect on cognition is something which is probably going to be studied later. So right now, in the context of obstructive sleep apnea, we mostly have data on AHI reduction and down regulation of some of the inflammatory biomarkers like high sensitivity CRP is down regulated with GLP-1s. But I don't think there's any significant data yet on cognition, but I think that might be coming once we understand how it impacts orexin. Yeah, that's a great question. Thank you.
He also asked if the risk for vascular dementia is greater in OSA and Alzheimer's disease.
So in that one study that looked at that, actually, the risk of vascular dementia was about as high as Alzheimer's. I think the hazard ratio was like 4.7 versus 5 point something. So it was close. I mean, it was quite high for all-cause dementia, Alzheimer's, and vascular, for all three of those. And I think part of the reason is that OSA produces dementia through various mechanisms. I mean, there is, of course, the risk of AFib and embolic strokes, and also hypertension and ischemic strokes. So vascular injury, definitely. But there are also other risk factors like upregulation of inflammatory biomarkers, endothelial dysfunction. There's some microneuronal injury from that ischemic reperfusion injury that happens over years of untreated OSA, which can produce, more neuropathology other than just the vascular aspect of it. So all-cause dementia, AD, and vascular, they're all high in OSA patients.
Thank you. Andre, please unmute yourself and feel free to chime in.
Hi, Chitra. Nice to see you. Thanks
Hey,
so
good to
much
see you as well.
for joining us.
Yeah,
Such a great talk as always. And I was
thank you.
typing my question in the chat, and I figured it's easier to ask. And so, you know, the data you have presented, shows a very strong relationship between, risk of neurocognitive impairment and maybe, even dementia with OSA, and then observational studies showing that, if you use CPAP, adherence specifically actually correlates with improvements in outcomes. But similar to, like cardiovascular disease outcomes and CPAP, those things are kind of biased towards the healthy user effects. And I wonder in your literature review, whether you've come across, any randomized clinical trial data that suggests that you actually can improve attention or learning and memory or, executive function. And so that's
Yeah,
my first question. I have other questions too, but I wanted to get a sense
yeah,
from
no,
you
of
what your
course.
impression is.
So I think there is data on memory and attention, sustained attention or vigilance specifically. And those are directly also impacted by excessive daytime sleepiness. So it's partly because it improves EDS and so it improves these domains, but that's not all of it. I mean, there are studies which have shown improvement in efforts, but the improvement in the memory can continue up to 3 months. Same thing with vigilance. Executive function is not actually improved to any significant degree, unfortunately, in the clinical trials that have been done, because most of them are shorter durations of CPAP, usually 3 to 6 months. And executive function is really hard to improve. So I've used tasks of executive function in some of my research trials, and I mean, they are hard tasks to do, like Wisconsin card sorting, even in a healthy individual the error rate is not that insubstantial. And then showing a difference between cognitively impaired versus non-cognitively impaired can also be harder because in general, even healthy individuals don't perform at that higher level on some
Yeah.
of those tasks.
Yeah. I mean, the other question I have for you is presumably the mechanism by which treating sleep apnea improves neurocognition has to do with improving sleep quality, duration, improved hypoxemia. And so are there some tests that are sleep dependent that can be used to help assess those changes that are sleep related rather than perhaps something that may be affected by, drinking a cup of coffee or being awake at the other part of the day than you would be otherwise?
Yeah, no, that's a great question. So there is sleep dependent memory, which actually hasn't been studied that well, unfortunately. And that would be an easy target. There's sleep dependent memory, which can be studied, which should be studied more in OSA because OSA has a direct impact on that. And you're right. I mean, sleep fragmentation, the hypoxia that is seen in the night, the microarousals, all of those have an impact on cognition. So definitely improving that can produce some improvement in cognitive domains, but sleep dependent tasks haven't actually been studied that well.
I have a question for you as well, but Dr. Sophie Rowe was saying thank you for the fantastic presentation, and she's curious as to whether you or any of your colleagues have studied how comorbid OSA and excessive alcohol use or alcohol use disorder might exacerbate cognitive effects.
So I didn't come across any study, and I have not conducted any studies on comorbid OSA and alcohol use, and I didn't come across any published literature either. But I would think that if both exist together, I mean, obviously, I would expect it would have a greater impact on cognition. But I have not seen any significant data to that regard.
Thank you. I'm also wondering, you mentioned that a lot of data about improving uh, attention deficit and vigilance and potentially working memory with use of CPAP. But did this include mild sleep apnea, or was this specifically moderate and severe sleep apnea that they were addressing in these
So,
studies?
so most of these studies have looked at moderate to severe sleep apnea. So the study that, the one of my earlier studies that I had shown earlier, so that actually we looked at risk for sleep apnea, not specifically, we didn't do sleep studies in those patients, but we have published some other data on improvement in MCFSI scores with CPAP adherence. So we have shown that if people are more adherent to CPAP, their cognitive scores improve, and that was actually all comers with sleep apnea, not just mild versus moderate. That was a treatment study that we had done like a few years back. But most of the published data from other authors that I've come across, most of them have looked at AHIs of 15 or greater.
Is there any data on mild sleep apnea and cognitive impairment that you're aware of?
Um, I have not come across actually anything substantial for mild OSA, and that is a great question because it is often a subject of debate whether mild OSA should be treated.
Right.
And one reason to treat it would be if they had MCI, provided we showed some improvement in those deficits with treatment. But I have not come across any significant data to that in that regard,
Okay.
actually.
Yeah, it's interesting because a lot of, emerging data suggests that there may not be benefit to treating mild non-hypoxic OSA to reduce cardiovascular disease risk. But MERGE study shows in mild sleep apnea with excessive daytime sleeping a significant
Mm.
improvement in quality of life with CPAP. So
Yes.
I get a lot of
Yeah.
referrals from neurology with these patients that are getting worked up for dementia, and they do a HST to try to do anything they can to improve their memory, and they have really mild sleep apnea, like AHI between 5 and 10, maybe 1 to 2 minutes, less than 89%. And the neurologist wants us to give them CPAP. The patients really don't want to use a CPAP. What are your thoughts in those cases? Clinically, what would your approach be?
So I think most of the data comes on sleepy patients, but there are some ongoing studies on non-sleepy mild OSA patients on which we don't have data yet because it isn't there right now. But I think those trials are underway. Um, Personally, I think the AHI has less to do with cognitive issues. It's probably hypoxia and sleep fragmentation or which probably have more to do with and of course there's microarousal index. And I know, Andre, you do a lot of work on EEG, right? So things like spindle density or something which might have so there are other markers of why cognitive issues can happen even in milder cases. So I would not put that much score just by the AHI. If people are
Mhm.
symptomatic, my tendency is to treat them, especially if they have cognitive issues.
So, based on AHI alone with cognitive issues and absence of daytime sleepiness, you wouldn't necessarily treat. You wouldn't.
So if they had cognitive issues, even if they had mild OSA, but they were not necessarily sleepy, because sleepiness is also subjective. I mean, Epworth is kind of a subjective tool, and it's not the gold standard. And there are people who are really sleepy on objective testing who are really not sleepy on Epworth. So how we measure sleepiness is also, you know, it's not like 100% that we aren't like spot on accurate that this patient is actually sleepy or not. So I think if somebody had cognitive issues, even if they had mild OSA and they were not sleepy, because we do know sleep
And
apnea doesn't act.
non-hypoxic,
What's that?
sorry, non-hypoxic sleep apnea, non-sleepy sleep apnea with memory being referred because of memory loss. So your tendency is
I
to
mean, my
treat that.
advice would be to treat them because I don't think we entirely understand the mechanisms by which OSA causes cognitive issues. So if you see MCI with OSA, even if it's mild and they're not sleepy and they're not hypoxic, I would probably still tend to treat them.
Okay. Okay. Good to know. Thank you so much. Does anyone else have any other questions? If not, thank you so much, Dr. Law. This was an incredible presentation, very informative, and we really appreciate having you here today.
Thank you so much. It's good to see you all again. Bye-bye.